giving us a brief overview over the week, about the week that has gone, and about certain things related to the updates of COVID, as usual. And after that, we are going to be having Dr. J.S. Arora, who is the current General Secretary of the National Thalassemia Welfare Society, who's also been the founder president of the same, and he's going to be talking about a brief overview of thalassemia. So thalassemia is one of the diseases that it's there, and it's not spoken about much. So we are very, very happy to have Dr. J among us, and who's going to be giving us a brief overview on the same. Without much ado, I would request Dr. Nidhi to please come forward and start off our session. Over to you, Dr. Nidhi.
Thank you so much, Dr. Meenakshi. We decide each week that we will not talk about COVID, and then we end up doing an update. But I think just doing this brief update till we officially declare it over is going to serve us well, because cases will keep coming and going. And if there is anything current, then we should be apprised of it. Also, it's been, we lost our mentor on the 17th of May, and this is like a year of carrying this active spirit. So we have paid a heavy price, and for those who say that it is nothing, I think the people who have suffered, the people who, every single person who has suffered is witness to the fact that it is more than we remember him every day, but I wanted especially today to be the time that we honor his memory by remembering what he has started, and keep that light on, keep that torch burning. So why am I saying that the pandemic is over? Not just Delhi. Of course, we wanted to figure out what was happening with Delhi and why were the cases rising so steeply. But as I told you, that when you have one case, then even one more is 100% increase. So going by percentage increases is not the way to follow a zero survey that has been done very, very recently. I think this is a February survey, shows 97% prevalence of antibodies. They don't yet know whether these antibodies are vaccine induced or infection acquired. But a good proxy of that would be the seroprevalence in children, which is matching that in adults, which means that this is perhaps a naturally acquired seroprevalence. The women are slightly more seropositive than men. Reasons I can't say. They generally stay at home. They generally, but they also do all the household work, usual grocery shopping and stuff. 90 to 88% difference, which is not very significant. When we look at those 90 and 88%, we would think that 97% is an overestimation, but this rate has been adjusted for test kit sensitivity, and the actual seroprevalence in the community is 97%. That is way above the benchmark for herd immunity, if at all herd immunity is a thing in COVID, since new variants of infections. It's lowest in Southwest Delhi, around 93%, and highest in East Delhi, around 100%. The solution to COVID might be hiding in plain sight. If we look at what was happening with Spanish flu uh, fresh air, rest, sleep, sunshine were compared in the sanitariums were having all those with the army hospitals, which had more crowding and symptomatic treatment, bringing down fever, etc. The uh, the infection fatality was reaching nearly 6.5% in hospitals, whereas it was only about 1% in sanitariums. Not to say that if a patient needs hospitalization, you don't hospitalize him, but as Sir used to say, that prevent every mild case from progressing to moderate and every moderate case progressing to severe. Try and offer holistic and comprehensive care, not just care for a symptom or a disease. The specific thing about SARS-CoV-2 is that it suppresses innate immune response as it runs like a wildfire through the body. There is a specific suppression of interferon response, which causes the virus to go out of control. The role of interferons we've all seen. The significant thing that comes out of these studies that have now been highlighted is pyrotherapy an option? Should we be suppressing fever comprehensively? So if, which is why, Sir used to say that go for mefenamic acid. Not only is it going to take care of the fever, but also of the TNF alpha response that comes in with the innate trigger in COVID. Pyrotherapy is not new. Pyrotherapy has been used in neurosyphilis in the past. Yes, it was before the onset of antibiotics. And interestingly, at that time, people used to infect the neurosyphilis patients with malaria, causing high-rise fever. And when they used to determine that the neurosyphilis has been cured, they used to then give chloroquine to take care of malaria. We have better options now, but the body responds with fever for a reason. The virus cannot survive in that environment. And this has been shown in the studies that have recently also come out, that rising core temperature and then bringing it down with hydrotherapy might work better. There is significant role of movement and ventilation, which cannot be overemphasized. So it has been 2 years and we are still walking that slow wild forest path where we are losing the trees for the forest or forest for the trees, depending on what view we are taking on the disease. We did discuss the Red Queen hypothesis, which says that the virus evolves for its own survival and our immune response after education evolves for its own survival. So immune education, natural immunity, improved adaptive immunity are all key factors to improving survival, decreasing infections, and gradually lower peaks of emerging waves. But there are some ways in which we can improve innate immunity. And those methods we have explored in the past. Get good quality sleep, deal with obesity, augment vitamin D, and sometimes let the fever run its course for a little while. Nutraceuticals do benefit, specifically the antioxidants. There is a role for risk stratification. So elderly males with comorbidities must take extra care. We have seen in seroprevalence also that the males have slightly lower seropositivity. We have to grow our mental bandwidth as this pandemic has adequately taught us. We need the medicine, we need the logic, but we also need the philosophy to discern where and what is the appropriate action. If we look at Sweden, why I wanted to bring that out was that look at where Sweden has largely been open throughout the pandemic. There have been no lockdowns. Yes, there has been good vaccination coverage, but there have been no lockdowns. Now, as of May 3rd, their daily case counts are around 400. Daily deaths are around 9. But throughout the pandemic, they have stayed well below their usual, they have been in the minus. The excess mortality has been in the minus. And if you look at the waves of epidemics that they have had the 1918 Spanish flu, where there is a significant peak, cholera, where the peaks were higher than their average, the 1857 dysentery, the Asiatic cholera. So they've had their brush with diseases. They have decided on a course of action that works for them. And in the pandemic of COVID also, it seems to have worked for them. If we look at what is the situation in the world this week, this was the rise of the Omicron wave and the fall right now significantly. Even the global case numbers are falling. Yes, there are some islands where we will continue to see emergence. South Africa, notably in the last week, the daily deaths had gone up to about 13,000, which was lower than the previous waves. By the end of March, they had come down to a third of that. And then by the middle of May, they have come down to about 50% of even that. The three big countries, if we look at COVID numbers, US seems to be showing a slight uptick again. UK is showing definitely going down. South Africa has begun to show a slight uptick again. India seems to be touching the baseline. There is a lot of talk about India not reporting enough. But if we look at what is happening around us, we know as doctors that we are testing whom we are suspecting, and our systems are currently not overburdened, and we are practically open. I mean, if you go out into people wearing all sorts of masks, not just N95 respirators, and whenever a new variant emerges, we go from 2-digit to 3-digit and perhaps to 4-digit, and then we fall back again. If we look at confirmed million, April, we were, US was leading the table. January, April 21. January 22, when Omicron wave hit, again, US was head of the table. We have had a share. It's not as if we've not been there. But around the middle of May, we have fallen back into, and for those who say that the BBC report and the WHO report are castigating us for hidden figures, I think scientific analysis shows that statistical methods can prove anything, and the ground reality is very different. WHO has used mathematical formulas to predict how many deaths we have had, and if we look at the numbers that they're projecting, then our normal deaths would fall, normal as in what is our average death rate, would fall well below that benchmark of last 5 years if the WHO numbers are to be believed. We have a very robust system of birth and death registration in our country, by the way, which is what WHO has ignored and has used statistical methods to predict. Vaccination status, we still have African countries well below the world average. We have most of the countries getting into the herd immunity status with more than 60 to 70% vaccination. Omicron is still the leading variant, but there are new sub-variants of Omicron which are emerging, and the current one, the BA 2.12, 0.1, 2, and 3 are the ones which are now perhaps driving the wave in US. If you look at the comprehensive data, look at the population of US here. Look at the population of India, the population of UK. We are, these are the total number of deaths, the total cases. New cases, China has shown nearly 300. US is now showing recoveries. So overall, these columns are running mostly empty. If you look at India specifically, we have reached a big number cumulatively, and now it is flattening. Now we are not rising in those, in those sigmoid fashion. Active cases are less than 20,000 and falling as recoveries are increasing. Daily new cases, if you look at January, we had a 350,000. In February, when we had the Omicron peak, January, February, we had a maximum of 10,000. In March, when we thought that we were going to have another peak, we had nearly 3,000. April. We are again seeing a fall back. The new deaths, even here, we were in 3 figures. But in May, we have fallen to double figure. And these are, even a single death is undesirable, but the deaths are not rising. Even with those 3,000, 4,000, the deaths are not rising. Hospitalizations are not rising. ICU admissions are not rising. So India is running very close to the baseline, whether it is because of decreased reporting, decreased testing, or other demographic factors, remains to be studied and published so that the West can understand our response to the pandemic. The fact that we have the experience of dealing with such a big population and have good, robust data collection as well as good, robust public health programs which have shown their success in the past, we must not always, just we do deserve the respect that we have earned. So if we look at the, the detail, US is also kind of just going up and down, but slightly going up. India is comprehensively down. If you look at the R number, the effective reproduction rate, US is showing a slight uptick, approaching 1.5. India is coming down. US is below. UK is below 1. So their pandemic also has been declared over. Most of Europe is now not asking for masking or testing or anything. They are carrying on with life as usual. It's only for international travel that they ask you to submit your immunization certificate. If we look at Delhi, you see this. We saw this bump and we were saying कि बढ़ रहा है तो हमारे को देखना पड़ेगा, but now that bump is coming down again. We are now less than the 7-day average. The end of last month, we were slightly above the 7-day average. The middle of April, we were slightly above that 7-day average, but now it is down again and comprehensively down. So it's not an artifact. This is something that I would like to emphasize. This study has been done in Luxembourg. It's a very small country. And they did a study of people who were physically active and try to associate that level of physical activity with the severity. A prospective study, and they checked the physical activity levels of the year before COVID hit. So the mortality is higher in the elderly. There is about a 6% rise with every decade increase in age. The high-risk associations are old age, obesity, smoking, autoimmune diseases, hypertension, cardiovascular disease, diabetes mellitus. We all know this. This study studied about 450 adults who were in the range of 31 to 51 years old. And they found that insufficient physical activity is associated with, no surprises, reduced cardiovascular and respiratory reserve, a greater incidence of obesity, and a greater incidence of chronic inflammation. They also propose that physical activity is a modifiable risk mitigator. Very little physical activity can modify risk to a very large extent. They investigated the association of most common symptoms: fever, headache, dry cough, respiratory problems, fatigue, with the level of activity in the preceding year. They found that there were 63% cases who were mild, 24% moderate. None of the physical activity adequate group needed ICU admission, and they all showed good recovery. On each of the symptom trackers, the physical activity was found to significantly statistically reduce the risk. So risk mitigation is simple. It's not easy. I mean, it's not easy to have the discipline to work out every day, whatever that workout may be, whether it is yoga, whether it is walking, whether it is running, whether it is weightlifting, HIIT, but it is a simple measure. If you can take out 20 to 30 minutes of your time every day, and we have been saying that, you know, the 6-minute walk test is a third of the time that you need, and you're going to be doing that anyway. If you do 10 squats every minute on the hour of your waking time, that's not, it's just going to complete your 30 minutes of activity. So risk mitigation is not difficult, but it is not easy either. It lowers the risk of chest pain, fatigue, and dry cough. It improves cardiovascular and respiratory reserve. It improves the immune responsivity so that the body is able to fight. Response to vaccination is stronger. There is an improved M1 macrophage and anti-inflammatory cytokine ratio so that the body is in more anti-inflammatory state. The physical activity is associated with enhanced immune surveillance, reduced systemic inflammation, improved regulation of response, and delayed onset of immunosenescence. Even 3 to 5 sessions of half an hour to 40 minutes a week lower the neutrophils, which calls for decreased inflammation, raise the CD4, which is a faster and a more robust response to incoming pathogens, and significantly increases salivary IgA so that there is better mucosal immunity. Also, we have been observing that, yes, in certain cases, children have suffered MISC, but it has been significantly lower than the cytokine storms we've been seeing in adults. So is there something which is protecting the kids? it appears like the children have a pre-activated antiviral innate immunity in the upper airways. Again, a study which has been published as early as August 21, when the Delta wave was at its peak. They say that the children do seem to have an immunological advantage. Natural immunity, both in adults and in children, cannot be ignored. Blindly boosting may do some harm. We must figure out a boosting strategy for high risk populations and encourage individualized medicine at the level of the individual practitioners. So the molecular mechanisms for better antiviral immunity in children are not very detailed, not very completely known. They need more work, but there is a higher expression of pattern recognition receptors like the MDA5 and the RIG1 in upper airway epithelium, the dendritic cells, and in the macrophages. What this results in is a stronger innate response and a quicker antiviral response. There is a distinct CD8 cytotoxic T cell population with enhanced memory, which is present in children's upper airways. The ACE2 and TMPRSS are not expressed differently. So the density of these receptors, the entry point for the COVID virus, are the same in adults or in children. This does not seem to be the reason why the children are better equipped to deal with infections. Rather, there is an enhanced recognition and viral sensing ability in the airway and the epithelium of the children. So we do need to stratify the risk in children also when we are talking about vaccinations in children. If we don't learn from history, we are condemned to repeat it. Whether Winston Churchill said it or George Santana, I don't know, maybe both of them did. But we need to learn our lessons. We need to actually individualize medicine, bring in the philosophy and the art of medicine with the science and deal with it better. Thank you very much, Dr. Meenakshi. And I'm sorry, Dr. Arora, I just needed to do this today.
Thank you, Dr. Nidhi, for that the wonderful celebrations and a detailed overview of COVID. We're just running a little short of time. So without much ado, I would request Dr. Arora, who so passionately feels about thalassemia and has been working on this for the last decade or more. So I would request him to please come forward and start off with his presentation. Over to you, Dr. Arora.
Okay. First of all, I'd like to thank Dr. Meenakshi and Dr. Nidhi for giving me a chance to speak on the topic which is very close to my heart. I am to thalassemia since 1991. So before coming to my topic or myself, first of all, I'd like to dedicate this today my talk to the great soul Padma Shri Dr. K.K. Agarwal on his first anniversary of new birth. Why new birth? Because sir used to say कि हमारी डेथ नहीं होती, हम एक नया जन्म लेते हैं. वो मुझे हमेशा याद रहता है. जब भी कोई की वो हेल्थ के बारे में बात करते थे, नहीं कोई बात नहीं, वो गया नहीं है, हमने एक नया जन्म लिया है. तो अगर मैं थोड़ा सा 2 मिनट के लिए सर के साथ अपनी इंट्रोडक्शन बताना चाहूंगा. आई केम टू हिज दिस लिंक व्हेन ही स्टार्टेड दिस हेल्थ मेला. वो पहला जब हेल्थ मेला था तब वो हमारे वही स्टार्टेड हेल्थ थैलेसीमिया कैंप ओवर देयर, वहां स्टॉल लगाते थे. And he used to encourage me कि आप वहां पर स्टेज पर आओ, क्विज यूज करो, and we'll give the prizes, gifts to all these things. And during all these years, we have been very close, and everywhere where he was there, he used to invite me for this thalassemia talk. अपना IMA ऑफिस जो है वहाँ पर सेंटर के पास इंद्रप्रस्थ में, I used to go there and give talk on the thalassemia. And recently during COVID, मेरे ख्याल है जब से वो आए हैं तो मैंने मुश्किल से शायद ही कोई गलती से कोई लेक्चर रह गया हो. And whatever I learned on COVID, it was all because of him only. I think everyone, but मैं अपनी बात कहना चाहूँगा, We never thought of giving this steroids to having in viral diseases, and that too in diabetic patients. But it was only because of his dedication, his confidence. वो इतने कॉन्फिडेंस के साथ मैं हूं ना, मतलब उन्होंने इतना हमारे को इतना ग्रेट बनाया. मैं कह रहा हूँ कि कोविड के अंदर मैंने जितने पेशेंट्स को अगर ट्रीट किया है, ऑलमोस्ट ऑल हैज बीन बेनिफिटेड एक्सेप्ट 1-2 जो हॉस्पिटल चले गए. एंड आई एम सो मतलब ग्रेटफुल टू हिम कि इट इज ऑल बिकॉज, अगर मैं आज जो भी खास तौर से कोविड ग्रुप में हूँ, इट इज ऑल बिकॉज ऑफ डॉक्टर के अरोड़ा. एंड आई हैव शेयर्ड मेनी प्लेटफॉर्म्स ऑन टीवी चैनल्स विद हिम. मुझे आज भी याद है जब पहली बार इस कोविड वैक्सीन की बात हुई थी, जब फर्स्ट टाइम गवर्नमेंट ऑफ इंडिया में एक न्यूज आई कि हम 15 अगस्त को कोविड लॉन्च करेंगे, तो सबसे पहली हमारी उसमें जो थी 15 CNBC आवाज और उसके बाद जी बिजनेस में, वो शाम को 5:30 बजे की बात है, डॉक्टर के अग्रवाल और मैं, हम दोनों ही एक ही प्लेटफॉर्म पे थे. तो हमने ये कहा कि ये हाउ दे कैन लॉन्च ऑन 15 अगस्त. एंड सेम डे वी हैड 3 sessions. Out of 2 sessions we were together, one in the CNBC and second at 7 or 8 p.m. at News 24. तो उसके बाद भी कई चैनल से हम साथ रहे, एक बार कई बार रहे. तो मुझे वो चीज कभी भूलती नहीं है. I'm clearly indebted to him for all this knowledge given by him to us. So as he used to say, the show must go on. I think all credit goes to Dr. Meenakshi and especially Dr. Nidhi for taking over the legacy of Dr. K. Agarwal. कि वो उन्होंने तब से लेकर आज तक, मतलब हर मेरे ख्याल शायद ही एक मिस किया मेरे ख्याल है, तो उन्होंने सारे प्रोग्राम किए हैं और बहुत अच्छा हम सबको जोड़ के रखा है. एंड एवरी टाइम कई बार सोचता हूँ कि मैं भी उतनी नहीं कर पाता, तो इतना बिजी होने के बाद भी रात निधि and Dr. Meenakshi or Delhi जो health अखबार आप लगाती हो. So so grateful to you. So now coming to my topic, this is my brief introduction. So we are here since 1991. I formed this society, the National Thalassemia Society. I was a founding president, founding general secretary federation, a member of many ethics committees, written some books, chapters, and got some awards, some IAP PHO award and this NCPD award. So all this is mainly I'm the member of WHO advisory group. I think Dr. K. Agarwal मुझे ऐसे इंट्रोड्यूस कराते थे. So this is a member of the advisory group of patients for patient safety. So coming to topic. So this Dr. Thomas Cooley, he first noticed Italian children with severe anemia and hepatosplenomegaly with growth retardation, bony changes, and discoloration of skin. And that he was, because he was the first to diagnose, so it was termed as Cooley's anemia in 1925. Since earlier cases were around Mediterranean countries, so it was also termed as Mediterranean anemia. And Whipple and Bradford termed as thalassemia. Thalas means in Greek it is C, great C, anemia, that is from the loss of blood. So our hemoglobin is made of beta and alpha globin chains. Beta chains on chromosome 11 and alpha chains on chromosome 16. This is the how hemoglobin is formed in our body in the very early gestational period when the alpha chains are formed, and but beta chains are not formed. At that time there is zeta and epsilon chains are there, and that is in the embryonic hemoglobin in the yolk skin. Then in liver and spleen, then this gamma chains are formed, but beta chains are slowly increasing. Then 2 alpha and 2 gamma form fetal hemoglobin. After birth, by 6 months of age, then there is some switch. It is believed that this gamma chains start reducing and they stop producing, while beta chains are produced regularly. So 2 alpha and 2 beta chains form adult hemoglobin, and there is a very less little gamma chains, and delta chains also start producing, and 2 alpha and 2 delta make A2. So at the time of birth, it is newborn hemoglobin A, that is adult hemoglobin, is 10 to 30%, fetal hemoglobin is 70 to 80%, and A2 is 0. While in adult hemoglobins, 94 to 96% is adult hemoglobin, 0 to 1 is fetal, and A2 is 2 to 3%. In thalassemia minor, which I'll come later on, 90 to 92% adult hemoglobin, 1 to 5 fetal, and 4 to 9% is hemoglobin A2. In Thal measure, A is almost 0, but in some cases maybe 10-20% or so. In fetal is 94 to 99%, and A2 is 1 to 6%. So an adult hemoglobin molecule is formed by this alpha and globin chains with iron porphyrin molecule in the center. In thalassemia, it's synthesis of either alpha or beta chains is reduced. In beta thalassemia, there is defective synthesis of beta chains, and the manifestations are due to excessive alpha chains, while in alpha thalassemia, alpha chains are reduced and excess of beta chains cause reduced survival. Alpha thalassemia is two types, alpha plus and alpha zero. Alpha plus is mild and its inheritance is of not much importance. And alpha zero is severe. You know it, you can say HB BATs, when the fetus died within the womb or just you can say immediately after birth. It's a severe variety. It is not compatible with the life. So, but in India, alpha plus is more common. So whenever we say thalassemia, it is automatically understood as beta thalassemia. This is the pathophysiology. In a normal, let's say hemoglobin, we have 2 alpha and 2 beta chains, normal erythroblast and normal red blood cells. If there is a reduced beta globin chains, that means there is a relative excess alpha chains, and that the excess alpha chains that aggregate, they become insoluble, and some HPA is there, and abnormal erythroblasts are formed in the bone marrow. The most of the erythroblasts die within the bone marrow, and that causes ineffective erythropoiesis. And that ineffective erythropoiesis causes increased iron absorption from the diet, and that goes to heart and liver and systemic iron overload. On the other hand, few abnormal red cells go to the this normal circle, and then again this alpha globin aggregates that damages the red cells. Then there's a hypochromic red cells and destruction of the aggregating containing red cells in the spleen. That leads to anemia. If due to correct anemia, we give blood transfusion, that again leads to iron overload. If there is reduced this blood transfusion, or we don't treat anemia, there's a tissue anoxia and erythropoietin is increased. And skeletal deformities, you can see the hair and skull. To simplify it, we can say that reduced level of beta globin chains is beta plus, because it can be beta plus and beta zero. If there is total absence, it is beta zero. In the both cases, excess of free alpha chains and excess of free alpha chains, the membrane damage to peripheral RBCs, causing hemolysis and anemia. And precipitation of RBC precursors within bone marrow, this is premature death of RBC precursors, and again ineffective erythropoiesis, anemia. And due to anemia, erythropoietin is increased, bone marrow expansion, skeletal changes, and hypermetabolic state. And due to anemia, as I told you earlier, there is increased iron absorption from the gut. If you treat with a blood transfusion, iron overload, liver cirrhosis, endocrine problems, and cardiac problems. So if you classify beta thalassemia, there can be 4 stages. One is silent carrier, which usually missed even by the hematologist as well. In this case, the condition is heterozygous. They are totally asymptomatic, no anemia. And this normal CBC, you can say, normal even HPLC. It can be diagnosed only by molecular studies, or whenever the partner of the silent carrier is a thalassemia minor, and then they may have an intermediate or major patient. Then we screen the parents, then we come to know that one of the parents is a silent carrier. In thalassemia carrier, they are heterozygous, having mild anemia. Especially, this is a very important thing, which I'll come in the later slides as well. If we look CBC very carefully, we'll see the RBC, MCP and MCH is very low, which is low in iron deficiency as well. But in iron deficiency, RBC count is also low. But in thalassemia, RBC count is higher in comparison to hemoglobin level. If you do HPLC, HbA2 is more than 3.5%, and that was again confirmed by molecular studies. Thalassemia intermediate is a condition between the carrier and the major. And it is also called non-transfusion dependent thalassemia. It may be homozygous or heterozygous, moderately anemia, non-dependent on blood transfusion, hepatosplenomegaly, growth retardation, bone marrow expansion, and may require blood transfusion occasionally during puberty, chronic infections, or pregnancy. And there is raised hemoglobin fetal hemoglobin and HbA2 level. Again confirmed by molecular studies. Thalassemia major, that is transfusion-dependent thalassemia, may be homozygous or even heterozygous. Severe anemia below the age of 2 years. Most of the thalassemia major are diagnosed by 2 years. And after those 90 to 95%, if you say around 50 to 60% diagnosed by 6 months of age. Markedly raised fetal hemoglobin, I told you, at around 80-90% or even 100%, confirmed by the molecular studies. So clinically say thalassemia minor, trait or carrier, they may be anemic, but life may be normal and healthy, and they don't require any treatment. That's a very clear message. I'll come later on as well. Thalassemia major, at the time of birth, they are hale and hearty. By 3 months to 6 months or maybe year or two, the child becomes pale, loss of appetite, retarded growth, delayed milestones, craniofacial and other skeletal deformities, hepatosplenomegaly, and if not treated, the death by the age of 5 years. Thalassemia intermedia, I told you they can maintain hemoglobin between 7 to 8 grams without blood transfusion and may require blood transfusion during puberty, pregnancy, or chronic infections. So if you don't treat thalassemia or don't diagnose, as we still see in the many smaller cities or villages, no treatment, life is just 1 to 5 years. If you give only blood transfusion, means you don't take out any extra iron from the body. It is 8 to 18 years. Blood transfusion and partial chelation. See, here I like to say that many places still adequate blood transfusion is not given. Usually we say to keep 10 gram or so, but at many places, because of various reasons, either blood is not available or blood transfusion center is not adequate, or at times even doctor is not aware. If you keep hemoglobin level 7 to 8 grams and don't give extra normal adequate dose of chelation, then life is 15 to 30 years. But this is again important. If you give adequate blood transfusion, safe blood means without WBC and HIV and optimum chelation, their life is as normal as it should have been thalassemia. Usually you must have seen some thalassemia patient with thalassemia cases, but these patients, if at all they sit with us in a group, we have now thalassemia patients going 45 to 50 years. They are, you can say, doctors, engineers, professors, running good business, earning children. So how to manage thalassemia? The actual aim is to prevent the crippling effect of anemia, ineffective hematopoiesis, chronic hemolysis, and iron overload to ensure normal growth and development. So to give repeated blood transfusion and maintain hemoglobin 10 grams, that is pre-transfusion, not post-transfusion. That is very important because we still see at many places pre-transfusion maintained around 7 or 8 grams, which is not correct. Iron chelation, splenectomy. Splenectomy meant at times when you are not giving adequate transfusion, spleen may enlarge. I'll come to later on some slides. Management of endocrine disorders, management of thalassemia bone disease, TTI, hepatitis B, and gene therapy. So when to start transfusion? This is again very important for our doctors. There is no hurry. Transfusion should not be started unless until final diagnosis has been made. We have seen many cases where it just if you see the hemoglobin level less than 7 grams and they give transfusion immediately. I say even if it is 4 grams, let it be an acute emergency. At least take blood for the HPLC and other iron studies and other things. At least you can diagnose before transfusion. To diagnose, then we have to rely on the parent study or we have to do molecular studies. In thalassemia major, as soon as it has been diagnosed, the transfusion should be started. While in intermedia, it is only when hemoglobin is less than 7 grams, there are facial changes, leg ulcers, poor growth, or poor weight gain, bone fracture, puberty problem, cardiac problem. Then in thalassemia intermedia, as and when required, the blood transfusion should be given. Again, I'm repeating, thalassemia status must be ruled out before blood transfusion in infant or child. Again, confirmed diagnosis And before starting transfusion, go for AB on red cells typing, and extending red cell typing is very important, because if after repeated blood transfusion, we have seen many minor antigen reactions, and that causes more hemolysis, and the blood requirement should also be typing should be done, C, C, E, and etc. Screening of patient for hepatitis B, C, and HIV, and hepatitis B vaccination if not already vaccinated, and family studies by HPLC for genetic counseling. Because at the time of diagnosis, first of all, the family is very motivated, and members, especially if it's a first child, then it will help the family to go for genetic counseling before going for next child. So mutation identification also help us in the future pregnancy, because that saves the time for CBS and other amniocentesis for the prevention, prenatal diagnosis. And secondly, mutation also tells us, okay, what will be the life of the child after that, how much blood will be required in the future. Level around 10 gram, 9.5 to 10.5 gram, and they don't require whole blood. It should be 7 days old, because the older it is, the less active is it. Their oxygen carrying capacity is reduced. And what is the dose, you can say, debate in 2 to 4 hours. Again, here I like to stress, in many places we have seen that this 1 unit of blood is given in 7 or 8 or 10 hours also. So after 3, it should be given 2 to 4 hours, not less than 2 hours. That becomes very fast. If you give after 4 hours, there is increased chance of having this bacterial infections. And again, one thing more, we have seen at many places, even a patient of BA50 at a time, which is not correct. If the patient may require even 1 to 3 units, the center says, we'll give you 1 unit today and take a break of 1 day, we'll give you next day, or third day, you come third day, or we play for 2 to 3 hours after give. It is not required, depending upon the weight of the child. How anemia, then you should not give more than 5 gram per kg body weight, and the speed should also be low, that is 2 ml per kg per hour, and 4 to 6 hours. Then we give it slow, and it should be with the diuretic. First degree relatives. Again, in many places we have seen where the blood banks are not very strong. Then they ask the family to donate, and that is parents, uncle, aunt, they donate blood. They should donate. That is okay. But their blood should not be given to these patients. It should be shared with other families. And moreover, minimize the frequency of transfusion. See, if you give 1 unit of blood to a 50 kg patient, then he will come every week. That means you are spoiling his life. He can't go to school. The family can. So give at least adequate quantity, though the child requires blood in 3 to 4 weeks. I told you the blood should be given the packed cells, but even by making packed cells, this transfusion reactions. So they should be given leuko-reduced packed cells. So leuko-reduction can be done at 4 stages, at many stages. First and the best is pre-storage. At the time of collection of the blood, it is done within 4 to 8 hours. This is the best, highest efficiency and high RBC recovery. And second stage is done the blood bank during the laboratory after that, and then at time some aggregates are found. And the last stage is at bedside filtration. At that time, even instead of giving with the BT set, it is given with the filter, bedside filter, and it do not prevent adverse reaction related to preformed cytokines. In some cases, what we have seen, even after giving packed cell with the leuko-reduced, still we have seen some reaction that may be because of plasma proteins. So there we advise to give wash cells. But again, one thing is there, and saline wash cells may target only proteins, not the white cells. So even if you are giving wash RBCs, then still you should give leuko-reduced blood. And secondly, it should not be replaced by the leukodation. If you are giving wash cell, that doesn't mean you should not use the filters. However, washing may remove some RBCs it reduces the effectiveness of the blood unit. What should do at a time of transfusion? So that you come to know if at all there is a reaction, you can go to the donor. Amount of blood transfused to know how much quantity is required for the year, height, weight, whether child is growing good or not, liver spleen cell size. It also tells you the effectiveness of this transfusion therapy and detailed. I was telling about splenomegaly. See, splenomegaly is very common thalassemia intermediate, that is anti-DT, because they are not taking blood and they are maintaining even 7 to 8 grams of hemoglobin. So that is the spleen is enlarges, and it is also seen in inadequately transfusion dependent thalassemia or transfusion thalassemia major patient, as because they are also having low hemoglobin. And sometimes it is so high that it increases the blood requirement, and it can say suppress or even compress the stomach, and the patient feels satiety and with a small food, so that will lead to malnutrition as well. And when to go for splenectomy? If there is an increase of annual blood requirement by 50% or more by the initial requirement, or it is more than 250 ml per kg per year, or sometimes because of that is a clear-cut indication for going for splenectomy. And I told you statin, abdominal discomfort, and radionuclear. Yes. See, if there is early splenomegaly, if there is slightly spleen enlarged, that can be reduced with the increased frequency of blood transfusion. So that is very important. We should not always try to take out extra, to take out the spleen from the body, because if you stage, and that can create another problem. So what you should do before splenectomy? At least it should not be given before 5. It should not be taken out before 5 years of age. And immunization is must: pneumococcal, meningococcal, and hemophilus and Hib, at least 2 to 4 weeks prior to surgery. Here I like to again stress that all these injections can be given on the same day. There is no requirement that you give this one today and then after while you go 10 days or so. But only thing is that it should be on 3 different sites, but can be given on the same day. After splenectomy, they are prone to having this infections, though it is advised to have penicillin prophylaxis 250 mg BD depending on the weight of the patient. We recommend throughout life, but at least for 25 years of age, those patients who cannot afford penicillin, they can be given erythromycin. Thrombocytosis, because after splenectomy, we have seen the platelets rise to 7 to 8 lakh or even 9-10 lakh. Hypercoagulable state, we should give aspirin 50 to 100 mg per day. And if there is having infection, though we usually say that patients should not take any antibiotic at home, but in these cases, we tell them anytime when you have fever, cough, cold, boil, any infection, you start amoxicillin and then come to as an early go to your treating doctor. And for the doctor, we say they should not wait for this culture code. They should start broad spectrum antibiotic immediately. We all know that our body takes 1 milligram iron per day from the gut, and it excretes 1 milligram daily from the stool. So balance is maintained. During the blood transfusion, see, each ml of blood contains 1.08 milligram of iron, and each unit 200 to 250 milligram of iron. And a child requiring 2 units will absorb 6 grams, that is 15 to 16 milligram per day. That is 15 times of normal what we take from the diet. And poorly transfused absorbs 1 to 5 milligram per day. Those who are under transfused. And our body has no mechanism to take out extra iron from the body because the iron is the most important element required for the various functions of the body. So what are the clinical symptoms of iron overload? The first and foremost is abdominal discomfort, lethargy, weakness, and fatigue. And this is the first symptom noticed by the parents. The child becomes more darker from their parents. Then they come to know their child as additional iron in the body. Liver fibrosis may start as early as 2 years of transfusion, and liver cirrhosis by age of 10 years if there is coexistence of B or C infection. Growth retardation, delayed and missed puberty, arthritis, and cardiac problems if you don't treat heart failure by 15 years of age. So, what are the organ damage by the iron overload? If it, see, pituitary, it's the first organ by the age of even 2 years, where the iron gets deposited as early as 2 years of age, and that causes impaired growth and infertility. In thyroid, it causes hypothyroidism, hypoparathyroidism, heart, cardiac failure, cardiac dysfunction, liver, hepatic cirrhosis, pancreas, diabetes mellitus, and if it deposits gonads, it leads. I don't know why it is. Yes. Iron overload and organs, this iron toxins are inevitable in the absence of intermittent therapy. Okay, next. How to measure this iron overload? See, it is not measured by this iron studies, TIBC, total iron, or transferrin level. It is only by the serum ferritin. Serum ferritin is a non-invasive, affordable, easily available, and can be repeated frequently. Generally, it correlates with the total body iron, but not too well with the liver iron. If serum ferritin, usually we have serum ferritin around 50 to 350 microgram per liter. But if serum ferritin is less than 2,500 microgram per liter, it is, say, you can say the patient will not have a cardiac problem. However, this serum ferritin is not so accurate, because if there is vitamin C deficiency, it is reduced. And if there is any infection or any inflammation, because it's an acute surface reactant, so that increases inadvertently. And so what we do is, because there is no other easy method, so what we do is, we do it serum ferritin level every 3 months, say 4 times in a year, and taking just odd men out. The best 3 which are correlated, we take those into account. Liver biopsy is very and neither easily available nor feasible for repeating testing. And even in that case as well, iron is not deposited homogeneously in the whole of the liver. So wherever you take the biopsy, only that part you will come to know whether what is the status of iron overload in the body. However, the new technology, that is MRI T2 star, sensitive to low iron levels and highly reproducible. It is reliably this iron assessment of the vital organs. Liver iron and cardiac iron overload have been calibrated and choice investigation. Calibration of iron assessment in pancreas and pituitary is under study, and shortly we may come to know. Moreover, this is done only on 1.5 Tesla scanners, not on 3 Tesla, because at the high 3 Tesla, that the higher levels are not accurately tested. No. So, how to interpret MRI T2 star values? For liver, we see this LIC, liver iron concentration, because we have calibrated with the liver biopsy. So, if it is less than 2, it is normal. 2 to 7 is mild. 7 to 15 is moderate. More than 15 is severe. While in the heart, we measure T2 star values, because it was not possible to correlate with the biopsy of the heart. It was done only with the cadaver's heart. So here we see T2 star values. If it is more than 20, it is normal. 10 to 20, moderate. Less than 10 is severe. And if it is less than 6, it is very, very severe, and we will lose the patient within 1 year. Higher the T2 star number, less the iron. Lower the numbers, more the iron. So T2 star is a dependable and reproducible non-invasive tool to measure iron overload in the body, especially vital organs like heart and liver. T2 star values help in choosing the chelator, because I'll tell you what are the medicine to chelate iron. So which one medicine chelates more iron in the heart, and other medicine the liver. So after T2 star studies, we can titrate the dose and know which chelator is better for that particular patients. And T2 star, if T2 star is not feasible, 8-10 places in all over India. So there our target should be to maintain serum ferritin around 5,000 nanogram. So why iron chelation? Because iron overload leads free radical generation that damages lipid membrane, DNA in organs, and cell death. So when to start chelation? Iron chelation started when serum ferritin exceeds 1,000 micron per liter, and usually this stage is reached after 12 to 13 transfusion. Or if it are there, you can measure the liver iron concentration. If it is more than 5 milligram per gram dry weight of liver or serum ferritin, that is equal to 1,000 nanogram per ml of the serum ferritin. In thalassemia, it is started much earlier when serum ferritin is around 500. Ferritin every 3 months. This is very important slide for benefit of continuous chelation, means early intervention and continuous treatment. See here, I like to mention the two patients, A and B. Both patients at the age of 3 years have serum ferritin less than 2 gram, and at around patient A started treatment chelation. Patient P did not start it. At 9 years, this B patient had short stature. At 12 years, diabetes. 15 years, he developed cardiomyopathy. Then he realized that he should take iron chelating drugs, and he started chelation. At 24 years of age, both patients had serum ferritin less than 2 gram, but still this patient was normal, while this patient still had, B patient has diabetes, cardiomyopathy, and short stature. There are 3 drugs available. One is desferrexamine, which is available for over 50 years. This is a calfer which was first launched in India in 1995, later in Europe 1997, and recently in 2012 in the USA. This is the only drug which was first stop for launch in India. Defoxirox is launched in 2005 USA, European Union 2006, and India 2008. Destrol injection, it is not absorbed orally, and it is available only in injection form. Half-life is just 5 minutes. That is why it is not given like any intramuscular, but slow subcutaneous injection is given over 8 to 12. The slower you give, the better it is. And if you give vitamin C along with it, the iron excretion is much more with Destrol. It can be given intravenous as well, but usually intravenous is given when serum ferritin is very high, more than 5,000, or there is endocrine or cardiac complication. But for this, we'll write that it should be referred to a referral center only, because the rapid intravenous infusion may lead to collapse. And side effects are visual and hearing impairment and growth retardation. And non-compliance due to cost and pain is evident in India. However, wherever it is free abroad, still patients were reluctant to take desferrexamine. When you're giving a Destrol injection or desferrexamine, how to monitor it? For compliance, you should you come to know that whether patients taken or not. And if there is induration because of your repeated injection, around 10 to 20 ml of fluid is going inside, then if you, there can be induration and pain. And at that time, because see, what we tell them, for one injection, they can give add 2.5 to 5 ml of water. So if they are giving one vial, we ask them to take 5 ml of sterile water. For 2, again 10 ml. For 3, even 10 ml is sufficient. And even up to 4 injection, 10 ml can be given. But if there is frequent induration, then we ask the patient to reduce it to 10 ml, means per vial 5 ml of sterile water. There may be rashes, fever. For that, you give antihistaminic, cortisone, etc. And ferritin quarterly. And that is important. Annually, you must check audiogram and ophthalmic examination. And if there is a problem, either stop the drug or reduce and reassess after 3 months. Now we have other drugs as well to give. Just sitting and standing height is should done quarterly. It declines in height velocity or disproportionately short stunts reduce the dose of Destrol and reassess after 6 months. Deferriprone, that is calfer, it is orally effective and absorption is delayed with meal. It is delayed but not hampered. If you give after meal, the absorption is delayed, but it will be same as it is given empty stomach. But it should be given after meals only. Half-life is 135 minutes, peak in 45 minutes. Excreted through urine. So that is why when you are taking camphor, then the color of the urine is dark. And when you start this drug, the patient may come and say that I'm having the iron. And as and when the serum ferritin reduces, the color of the urine becomes much less darker or lighter, you can say. Dose is 50 to 120 milligram per kg body weight, usually 75 to 100 milligram body weight in 2 to 3 divided doses. Most common reaction is nausea, vomiting, abdominal pain, distension. Arthritis, which we used to see earlier when the serum ferritins were very high, but now after this, people are taking regularly, so still reduced, but still we can have pain, swelling in joints, difficulty in sweating. And if we have this joint pains, and mostly knee joints, larger joints, and initial stage we can add NSAIDs, but if Brufen, etc. But if it is not cured, not relieved, then we either reduce dose or stop dose, and after 3 months or so, we can start with a lower dose and slowly increase it. Zinc deficiency in 1% cases, that is why we always give zinc, say like zinc, COVID, Zavit, etc. to cover up that deficiency. This is most important, agranulocytosis and neutropenia. We have seen the most common important side effect is that is TLC may be reduced, or you can say neutrophils and the platelets. So that is why by taking this drug, monitoring it should be done with HPTLC, TLC platelet every 3 weeks. And in case TLC is less than 3,000, neutrophil less than 1,000, or platelet less than 1 lakh, the drug should not be given till it returns to normal. And if it has come less than 500, then it should not be restarted, or maybe if at all to be restarted, only by a specialist who is dealing with the thalassemia patients. Combination therapy can be given and should be given when serum ferritin level is very high, say more than 5,000, or there is any organ damage, cardiac, endocrine, but this is at least preferably should be given by the referral center. Dose is individualized. It helps in reducing cost and side effects of both the drugs. And destrol, as I told you earlier during the MRI slide, that destrol is more effectively chelates liver iron, while camphor, diferriprone, is more effective in removing iron from the heart. So MRI tells us which drug will be more beneficial than particular patients. However, destrol and camphor act synergistically. They don't make 1 + 1 2, but 1 + 1 11. This is another third drug, defrosilox. It is oral, dispersible tablet, and administered just once a daily. Highly specific iron. It does not take out extra zinc and copper like camphor. And the most important is, since it is dispersible, it can be given to even a 2 years of age of a patient, because you can disperse the tablet in a water. And this can be dissolved in either the water or orange juice or apple juice. The most important thing is this is not the soluble like salt or sugar. It is just like sand, you can say. And once you give it, you may find some particles at the bottom. Then add extra iron, extra water, and you can shake it and give it to the patient. And moreover, that the drug should not be dissolved in a metallic container. It should be either a glass container and a plastic spoon or a glass spoon. That this is 5 times more potent than desferol and 10 times from diferriprone. Half-life is 11 to 16 hours, and the dose varies from 10 to 40 milligram per kg body weight, depending upon the iron level and the transfusion requirement. Patient taking 1 unit, 2, 3, 4, and patient weight and iron overload. It is once daily, empty stomach, at least 30 minutes before food. The tablet should not be chewed or swallowed, but dissolved the this glass of water I told you. The extra benefit of this defrosol tablet is that with camphor and desferol, we can't give below 1,000 of ferritin. However, we can bring to 500 nanogram per ml. And this drug is excreted 90% of feces and only 10% of urine. That means the color of the urine is not dark. So at times when we switch patient from diferriprone to defrosilox, patient may say, earlier I was excreting iron, now this drug is not effective. That is not true. This drug is taking iron from the body through stool. So side effects are 20% nausea, vomiting, diarrhea. Diarrhea is very common. And to reduce diarrhea, what we do is either we give the instead of giving empty stomach in the morning, we give at night, or we we divide the dose into twos. Like patient is taking 2 tablets, we ask the patient to take 1 morning, 1 night, and or 4 tablets, 2 morning, 2 night. So that way we reduce diarrhea. Diarrhea is very common. Skin rash is 5%, and that you can add either antihistaminics, reduce dose, and if it is severe, then give steroid for 2-3 days or maybe week or so, stop the drug, and after 2 to 3 weeks or so, then you start very little dose, 5 milligram per kg body weight, and then you can treat the patients. Side effects are mostly, you can say there is a mild non-progressive increase in serum ferritin. Earlier, we was very worried about this kidney function, though it was found in about 35% patients. But in very few cases, we have to stop the drug. Now, I still, maybe 5-6 cases, I have to stop the drug in last 10-15 years. And all these side effects are dose dependent. So you can resolve this with the either spontaneously or by reducing the dose or stopping for short term. It may increase the liver enzymes, SGT, SGPT. But if it is more than 2 times, 3 times, doesn't matter. But if it is more than 10 times, then you also look for other reasons, whether the patient has hepatitis because of hepatitis B, CO, etc. If there is no other indication, then if OTPT is high, then we stop the drug or reduce the dose and change the chelation to the 2 drugs. This may also cause hearing loss and cataract. So that is why we ask the patients to check their this auditory and ophthalmic examination once in a year. It does, like desferol, it does not affect the growth retardation and does not exceed zinc and copper, and no arthritis reported as in the diphenipron with deferoxilox. Yeah, there is a new formulation of deferoxilox with a film-coated tablet. It is in 90, 180, and 360 milligram, and here the dose is less. In that case, it is 30% less. There, I told you it is 10 to 40 milligram per kg body weight. Here we give 7 to 28 milligram per kg body weight. So there, if we are giving 500 milligram DT tablet, dissolved tablet, here we'll give 360 milligram. So accordingly, dose can be converted to this FCT formula. It has less stomach problems, or it can be taken with meal any time of the day and doesn't cause diarrhea usually. For combination, when it is required, postpone response to chelation monotherapy, intolerance to adverse. If one drug is not to be tolerated, then we can give other drug or reduce the dose, and all these things I have already told you. This is again covered almost. So when we're giving deferoxilox, the most important is this urea creatinine monthly and reduced if there is more than upper level of normal. Same way as SGT, SGPT, if it is more than 5 times of upper level of normal, and look for other causes as well. Urine protein should be looked if there is more than 1 plus. Ferritin, if it is less than 500, audiogram, ophthalmic examination, I told you, and rashes we can reduce, stop, or add this antihistaminics. How to monitor growth? Record length and height on every visit after 2 years of sitting and standing height as well, and weight be recorded every 3 months. Record parental height, calculate mid-parental height, and preferably same investigator, because every investigator has some different in checking the height and weight. If it is done by same left hand and wrist for bone age, evaluation of chronicle and bone age, if there is difference of more than 2 years. X-ray of spine, but this is usually required when we are giving desferol injections. Usually what we see, there's a normal growth till the age of 9 to 10 years, because at that time it is more dependent on the diet and the hemoglobin level. But mostly the toxic effects of iron are seen after 10 years of age. By this Tanner chart from the age of 10 years. If there is no pubertal onset in girls by 13 years, late puberty, and if there is a lack of pubertal progression over a year, you can say arrested puberty, and absence of breast development in a girl and testicular volume less than 4 ml in boys by 16 years, that means pubertal failure. So at that time, we need endocrine evaluation we have to see the growth velocities, filing, delayed puberty, all these things. We check the bone age, the endocrine, this evaluation by T4, TSH, LH, FSH, testosterone, estradiol. But that is again very important is early intervention can result into spurt in puberty. If at the age of 11 or 12 years you notice that the child is not going well and they're having a high iron or low hemoglobin, and if you treat aggressively, even at that moment, you can have a normal growth and normal puberty. These are the tests to be done, recorded every visit. So if you treat the child very well, here you'll see the family. This person is a boy, is a thalassemia major, girl is a normal, not even a carrier, and they are having a happy married life. They have now 2 children, are living very happy. So these are some of the activities we do for the awareness of the patients and the public. This is a book we have published, Care and Control. Dr. Nidhi, yes.
नहीं सर, आप कंप्लीट करिए उसके बाद.
Thank you. Next. This is again very important. This recently in RPWD Act in 2016. Earlier in 1995 Act, there were only 7 disabilities. But in 2016, we fought for 20 years that then we got this thalassemia included in the list of disabilities. The benefit is free healthcare, non-discrimination, and equal opportunity, especially in the employment. Earlier, what we have seen is the patient is the thalassemia patient was denied employment, denied job on medically unfit. But now they cannot be termed as unfit because of thalassemia. And there is incentive to employer who employs in private sector who ensure 5% job for the disabled persons. Free education, reservation is higher education. See, this has helped us a lot. Now our many patients, you must have seen the newspaper I showed you earlier as well, and they got this thalassemia in the disability list. It was not because they were given just any other priority, because earlier they were denied admission on the medical grounds. Now the government cannot deny it, and the Supreme Court has intervened. And I like to remind you of one case at the previous regime. One of the patients, before this act was passed, he was double masters, and he cleared in his this ICS examination, but he was refused this IES and this job employment on the basis of medically unfit. He was refused twice, first by Safdarjung Hospital, then RML. And then at the intervention of the Prime Minister, Dr. Manmohan Singh, then he got a job and he's working there. But that was only when the act was not passed. Now act is there, so they can be employed anywhere and cannot be discriminated just on the health grounds. So this is again this permanent cure bone marrow transplantation. See, if the patient is, the results are best if the age is, let's say, 5 to 7 years of age. Even up to 10 years is very good. But we usually try, should be before 16 years of age. The risk factors are liver enlargement, hepatomegaly more than 2 centimeters, liver fibrosis, or irregular iron regulation. Well, they have divided into 3 categories. Class 1 is the best patient. 90% is survival. 5% rejection means that disease comes back, again, thalassemia major, and 5% mortality. And this can happen in the best case. Doctor, best center. Class 2, and this is again, you see the increased mortality. Class 3, patient not maintained, then you see the mortality is 19%. For adult over 16 years, it is 35%. Though whenever you see a patient of thalassemia major, ask them to check their HLA typing with the sibling or the parents. Patient. So it can be bone marrow, the most preferable source. Usually we take this peripheral stem cell instead of from bone marrow. Cord blood transplantation was tried, but though it reduces the acute and chronic GVD, but not practiced these days. These days, matched undead donor are very easily come because the families are small. You don't get HLA matched donor within the family. So, so mismatched donor tried, but success is not good. Now coming to gene therapy, that has been tried, and there is one case of beta E and beta 0, who is transfusion free for over 13 years. Now it is under the study in US, UK, France, and 2-3 more countries. 5 years, but cost will be a problem for at least India. Prevention, because prevention is the only ultimate care. Thalassemia is there are 5 crore Indians who are thalassemia carrier. Why I am showing the picture of Amitabh Bachchan? See, a person who is 80 years of old, and he is most active than what we are sitting over here, and he has no depth of resources, and he is a thalassemia carrier. Since Jaya is not, so children are normal. So if Amitabh Bachchan can be a carrier, why I and you cannot be a thalassemia carrier? So in India, it is 1 to 17%, around 4% average. 10,000 to 12,000 thalassemia major born every year, up to 40% in some areas. HBE in common in same like beta thalassemia, most common in West Bengal and this northeast states. Alpha thalassemia not significant. In Delhi, 1 out of 18 is a thalassemia carrier, and 1 thalassemia child born every 45 minutes. I think by the time we finish our whole session, the 2 new thalassemia major have born in the India. I told you 1 to 17%, 1 to 3% South India, 3 to 10% North India, 3 to 70% Gujarat. Carriers around, I told you, 10,000, 50,000 born every year. Now come. So this, if husband and wife both are thalassemia carrier, in each pregnancy there is 25% chance. If child takes both normal gene, the child is absolutely normal, better than parent. 1 normal, 1 abnormal thalassemia carrier like parents, both abnormal thalassemia major who will survive on repeated blood transfusion. This is very important that some countries, India, Greek, Italy, and Thailand, within 10 years they control thalassemia. In 1974, Cyprus started this thalassemia control program by carrier detection, but the most important role played marry only when you show your thalassemia carrier status. Unfortunately, in India, even though our marriages are those who say settled in heaven, but there is a involvement of Pandit for Janam Patri, Janam Kurli. If these Pandits, Brahman, whatever it is, if they support, please also go for thalassemia carrier status. We can at least we can also eradicate thalassemia from India within 10 years. So this is again important slide. I like to show this study torture of a thalassemia child who suffered for 30 years. She had all taken 840 units of blood, 16,800 units of desferol, for 72,000 hours. The needle was in her body for desferol injection, and she has incurred 33,60,000 afforded, but only because her father was alive. And if she lives for 60 years, maybe even 70, 80, let it be 60 years, she will injections and 1.2 lakh hours of needle in the body, and again 60 lakhs for the desferol therapy. And why there is a need for prevention? Because it is a commonest single gene disorder, and it is preventable. And government requires at least 1,875 crores per year to treat 1.5 lakh thalassemics who are living on regular blood transfusion, and 40% blood is used by thalassemic. Once a thalassemia major is diagnosed, this is for the gynecologist. Family starts cursing obstetrician for not advising thalassemia test. Unfortunately, our gynecologist is advising hemoglobin, 6 times ultrasound, urine, all these things, hepatitis B, C, HIV. Nobody is refusing, but they are not advising this HPLC. So I think if our gynecologist does, then we can prevent this thalassemia. And this is very easy. And for all our doctors, see, usually what we see is HB, TLC, TLC platelet. If we just see 3 parameters, nothing else, and nowadays all this CBC is done on cell count. MCH is less than 27, MCV less than 20, 80, it may be iron deficiency or thalassemia carrier. But if you see RBC count higher in comparison to hemoglobin level, that is very important. See, if hemoglobin is 9 gram and you see RBC is 5, 3. Same way, if hemoglobin is 12 or 13, and the RBC should be 4.5 million. Why it is 6? So if you just look into it, you will come to, you can suspect the patient is if HbA2 is more than 3.5%, the person is a thalassemia carrier. And it should be done just once in a lifetime. Why not to act as early as possible? So again, anemia is a no criteria. I told you many times we have seen the gynecologist refusing to go for HPLC, saying your hemoglobin is normal. You don't have family history. No, not at all. If your MCV, MCH is less than 80 and MCV less than 80, MC less than 27, even if your hemoglobin is 14, 15 grams for males or 14 grams for females, and then you should suspect you may be a thalassemia carrier and advise thalassemia carrier status. Here you see the example: 11.5 gram hemoglobin, MCV 88, MCH 28, and A2 is 23. Person is not a thalassemia carrier. And another case, 14.2 gram hemoglobin, and you see MCV. So never look for the hemoglobin level alone. Look for MCV, MCH, and RBC count. These are some formulas by differentiation between IDA, iron deficiency anemia, and the minor. There are men's index less than 13 is the minor, and more than 30 IDA. And then shine and all is very common. Less than 15, 30 is a minor, more than 15 IDA. But this is a very time consuming and not accurate. So you go for simple MCV, MCH, and RBC values. And that is how to interpret HbA2 level. If it is less than 3.1, it can be normal or alpha thalassemia trait. If it is 3.1 to 3.9, it may be beta thalassemia trait with iron deficiency or interaction of alpha and beta thalassemia. If it is more than 3.9 to 5, 9, it is beta thalassemia trait. More than 9 is HbE syndrome. There are these, every country has different mutations. So in our country, there are around 20 common mutations. After these 20, this 1, 2, 3, 4, 5, 6. 6 is more common. And again, other 6 are little bit less common. Here the role of every doctor, I must say. See, obstetrician can rule out thalassemia carrier status whenever the lady first visits for the antenatal checkup. General practitioner, they can diagnose with routine when they are going for infection, anemia, anything. You are going for CPC. Why not to look into MCV, NCH? If you are suspecting, ask the patient to go for the HPLC test as well. Same a pathologist, while looking at MCV, MCH, they should advise HPLC test so that patient as well as doctor becomes aware. Dietitians, while providing the best treatment, they can guide the family that yes, if you have a patient in your family thalassemia major, your family members will be thalassemia carrier. Check your patients. And sometimes you see this general public that they believe more in the paramedicals. They believe they trust more than nurses, lab technicians, chemists, pharmacists, even more than the doctors. So they can be very helpful in spreading awareness and asking the public to go for thalassemia carrier status. So I must say that charity begins at home. I always request that the doctors, if anyone in their family is unmarried or still planning to have a family in the after marriage, they should check your thalassemia carrier status. Because if you become aware of thalassemia carrier status of your family, then I think you will be more proactive and a good spokesperson for spreading the awareness. So their message should be clear. Carrier stage has no disadvantage. They're absolutely normal and healthy, and they don't require any treatment. The only risk arises when both partners are carrier, and moreover, the homozygous state, that is thalassemia major, is fatal, and it is a crippling. It is a more traumatic, costly treatment, and fetal diagnosis is available. Then you can prevent it. Why not to prevent it? See, this is the formula how to prevent thalassemia major in a newly married couple. You can say, screen the pregnant woman on the very early first visit. If she is positive, ask the partner to be tested. If husband is not a thalassemia trait, no action required. If husband is trait, go for prenatal diagnosis. If fetus is a normal or thalassemia trait, continue to have a safe child, safe pregnancy. And if the fetus is major, family can go for abortion, whatever it is, their choice. So where you need to go for partner testing for prenatal diagnosis. If the partner need to be tested, if the lady is beta thalassemia trait or delta beta trait, HBS trait, sickle, HBE trait, D trait, or D thal. D thal means homozygous, or cow thal, cow homozygous. And prenatal diagnosis is required only When there is beta thalassemia trait, both husband wife, one is trait, other is HBE, beta trait, sickle cells, both sickle D, and delta beta beta thal, and delta beta and beta thal major. It is not required. Beta thal prenatal diagnosis is not required if both partners have HBT trait or homozygous. If both partners are HBE trait or homozygous, in one partner is HBD and other is beta thalassemia trait, it is not required. And if one partner is HBQ India and other is beta thalassemia trait, then still the prenatal diagnosis is not required. So this is the how to prevent chorionic sampling at 12 weeks of pregnancy, amniocentesis 16 to 20 weeks, cordocentesis 17 weeks, you all know it, and maternal serum. Those studies have been done to go for prenatal diagnosis by maternal serum, but still it is under trial. So what is the cost if you go to a government setup? It is at Loknaik Hospital in Delhi, it is free of cost, zero cost. If you go to AIMS, it is again just 4,000, and same at PGI Chandigarh and SGPJ Lucknow around 4,000. However, private setup it is around 40,000 or so. This is pre-implantation genetic diagnosis. This is possible whenever a couple is having repeatedly thalassemia major child by CVS testing, then they go for this test. Or somebody doesn't want for prenatal diagnosis, and in some communities this abortion is not allowed. So in that case, they can go for PGD and they can have a directly normal child. These are few thalassemic children, and I always request all my doctors, all my colleagues, please help me. They should not increase to this level. So my last slide, inferior doctors treat full-blown cases, mediocre doctor treats to prevent complication, and superior doctors to prevent the disease. I think we all are sitting over here, superior doctors. You'll help us to curtail the birth of thalassemia major child. Thank you very much.
Thank you, Dr. Arora, for the wonderful deliberations and a beautiful insight into thalassemia. And I believe that this is exactly what we needed from a clinician's point of view. And you've covered every single topic related to thalassemia very, very well. I think, the patients, they keep asking us, there are certain multivitamins not allowed to take, and that is something, and a lot of medicines. So in the future, if you can just share those details, that would be great.
They can see multivitamins, they can take, no problem. Usually with zinc and B complex, we can give it. And we have to say only one thing. There should not be any iron. I'll give you my experience. We used to write beta toxin. And the beta toxin was the B1, B6, B12, etc. Okay? Yeah. That's multivitamin. And once I found that the patient brought me another iron. Sir, isme to iron hai. And that was beta toxin M. I never knew there is a beta toxin M. The chemist gave me, instead of giving beta toxin 12, he gave beta toxin 12M. So please ask whenever there is there, you tell your patient, you either it should be stick to your prescription. If at all the chemist want to substitute, they should recheck with you. It should not have any iron. Same way in this nutrition, like other Cerelac, all these things. And some places it is the extra iron. They're fortified with iron. That they should not take. See, iron to har cheez mein hai. Roti mein bhi, har ek mein hai. That doesn't mean. But only for diet, I'll say one thing more. See, if you take common की बात है, मैं पहले बात की होगी शायद कि if you take tea with the food, that reduces. सर शेयर करता हूँ, मेरी दादी कहा करती थी चाय मत पियो, ये खून जलाता है. तो उस समय तो I never knew कि खून जलाना क्या होता है. But now I know कि it reduces the iron absorption.
Yes, the tannins.
Ask our patients to take tea with the food. There is no use. Not take lemon things, means vitamin C that increases the iron absorption.
Right. Right. So that's all from my end. If there are any questions, we would be, I think Dr. Arora would be happy to answer them. So the floor is now open for questions. I think it's been a exceptionally long session today.
Sorry, actually, I never knew Dr. Nidhi there. I prepared for full 1 hour.
Sir, sir, I'm very sorry about that.
No, it's so nice.
It's okay.
But I really must compliment you both on the comprehensive for the subject, because sir, I have only one question. बहुत ही illuminating talk थी, eye opener in a lot of ways. I mean, when do the alarm bells ring? Because obviously we still don't have program, let's say.
See, alarm bell for two stages, major and minor. Okay, coming for minor means prevention. I think we should test every person the first time we ask for CBC. सिंपल सी बात है, बहुत आसान है. आप जब भी चाहे 2 साल की एज में CBC करा रहे हो, आप सस्पेक्ट कर लो, पेशेंट को बोलो कि नेक्स्ट टाइम जब भी ब्लड टेस्ट कराना है, ओके एक्स्ट्रा प्रिक मत लगाओ, नेक्स्ट टाइम जब भी टेस्ट कराना है आप HPLC साथ में करा लीजिए. अगर ये सब डॉक्टर्स हम लोग कर ले तो वी कैन प्रिवेंट इट. दैट इज द फर्स्ट. सेकंड इज वो गायनेकोलॉजिस्ट का. द मोमेंट द लेडी एंटर्स अ गायनेक क्लिनिक और ऑब्स क्लिनिक, शी शुड एडवाइज HPLC. मतलब मुझे बहुत अफसोस के बजाय मैंने कई बार गायनी प्लेटफॉर्म पर भी ऐसे ही बोला है, मतलब कम नहीं बोला मैंने उनको भी यही बोला है कि वो आपको कर्ज करती है दुनिया जब तुम टेस्ट नहीं कराती. वो करेंगे, मुझे जितने टेस्ट बोलेंगे मैंने सारे टेस्ट बोले. सी दिस इज द ओनली डिपार्टमेंट where the patient pays with the you can say smile. जब कहते जितने खर्च कराने करा लो. आपने हीमोग्लोबिन करा लिया, मैं सबसे बड़ा एग्जांपल दूंगा, HIV कराते हो, HIV is 0.25%
right
in India and thalassemia is 4%. यानी कि एक चीज जो 0.25% है वो आप हर एक का करा रहे हो, एक चीज जो 16 गुना ज्यादा है 4% है वो नहीं करा रहे. मैंने कहा लॉजिक बता दो मेरे को, व्हाट इज द लॉजिक, जो मोर कॉमन है वो बता दीजिए. तो मतलब मेरा तो कहना है जो नेक्स्ट स्टेज है वो गायने वाली आती है ऑप्स वालों की, पहली बार करा लीजिए. आपने HIV करा लिया, BC यूरिन करा लिया, 6 बार अल्ट्रासाउंड करा लिया, कोई मना नहीं करता आपको. कहते हैं मुझे कई, मैं आपको पर्सनली बताना चाहूंगा, मुझे कई बार बहुत क्लोज फ्रेंड्स हैं, एक मतलब मेरी बचपन से मतलब बहुत छोटी थी वो, जब पढ़ती थी 9th क्लास में, शी बिकेम डॉक्टर, बाहर चले गई, बहुत दिन बाद मिली, सर आप बहुत अच्छा काम कर रहे हैं. ये मैं क्या, अच्छा तू ये बता तुमने कितनों का टेस्ट कराया? वो तो मैंने नहीं कराया. मतलब अब सी क्यों नहीं कराया जी? वो पेशेंट पूछता है जितने पैसे. मैंने कहा बाकी उसने तुमने जितने पैसे मांगे क्या उसने मना किया? आप कोई पेशेंट डिलीवरी पे सर्जरी पे मना नहीं करता, तो तुम्हें ये 500-700 हजार के लिए मना करेगा? तो मतलब कहने का है कि आप जब भी अगर छोटी एज है 2 साल से लेकर शादी से पहले कोई मौका मिले टेस्ट करा लो, और जब प्रेग्नेंट होती है तो एंटीजन चेकअप पे फर्स्ट डे में उसका टेस्ट होना चाहिए. ये तो अलार्म बेल हो गया प्रेगनेंसी वाला. दूसरा अलार्म बेल है पेशेंट के लिए. पेशेंट के लिए भी सबसे अच्छा है कि वो 2 साल की एज, मतलब 2 साल में ये ट्रांसलेशन स्टार्ट हो जाता है, 2 साल की एज से उसको 2 चीज ध्यान रखनी है. अगर सिर्फ 2 बात पेशेंट ध्यान रखेगा, पेशेंट विल बी एब्सोल्युटली नॉर्मल. जैसे कि मैंने वो दिखाया आपको, हीमोग्लोबिन 10 ग्राम, मतलब यहाँ मैं वो सलमान खान का डायलॉग बोलता हूँ 10 का दम, मतलब आप 10 ग्राम हीमोग्लोबिन रखो, आपको कोई चिंता नहीं होगी. तो हमारे पास डेस्ट्रॉल और कैल्फर होता था. जैसे ये न्यू ड्रग आई है डेफ्रोसिलॉक्स, ये हम 500 तक दे सकते हैं. कोई आस्क द पेशेंट टू कीप इट 500. हमारे पास ऐसे पेशेंट हैं हु आर कीपिंग जस्ट 300 आल्सो. हमें उनके डोज आधी कर देते हैं, यहाँ बीच में कई बार थोड़ा गैप डाल देते हैं. सो 2 अलार्म बेल्स, 1 इज, और अच्छा इसमें एक चीज और है, अलार्म बेल आपने आप बोला तो खास तौर से 10, 11, 12, 13 साल जब वो उसकी ग्रोथ प्यूबर्टी स्टार्ट होती है, उस टाइम पे वी हैव टू बी वेरी एग्रेसिव. अगर उसमें कोई कमी रह गई है पहले 10 साल में, वो हम 2-3 साल में कवर कर सकते हैं. अगर किसी पेशेंट ने पहले 9-10 साल में कोई कमी करी है, मैं इसके लिए भी आपको बताता हूँ. बट आई से मैंने कहा जी आपकी पढ़ाई कितनी भी खराब हुई हो पहले 7-8 साल, 7वीं 8वीं 9वीं तक, अगर आपका 10th का बोर्ड अच्छा हुआ है, आप आगे लाइफ में अच्छा कर सकते हो. और 10th के बाद आपका 12th का बोर्ड है, अगर आपने 12th का बोर्ड भी अच्छा कर लिया तो यू कैन बी इवन IAS अफसर. आप कुछ भी बन सकते हो, इंजीनियर, डॉक्टर बन सकते हो. अगर आपने 10th और 12th मिस कर दिया तो आप बाद में रिकवर उम्र 10 साल की उम्र में एक्शन लेना स्टार्ट कर दिया, या 12 साल में प्यूबर्टी से पहले स्टार्ट कर दिया, तो आपकी प्यूबर्टी फर्टिलिटी ठीक रहेगी. अगर आपने नहीं किया तो आपको बाद में जब 18 साल 17 साल हो जाओगे, कोई दुनिया की ताकत नहीं है आपको रिकॉर्ड. तो मैं हेयर मतलब मेरे तो एक जनरल जो लाइफ के एग्जांपल्स मैं अक्सर देता हूँ.
No, definitely. These are the little clinical pearls that we want. And in fact, the presentation में जितना नहीं सीख पाते उतना बाद के जो ये examples हैं, we really learn a lot from them. So a big thank you to you, Dr. Arora, for sharing these clinical pearls with us. सर भी ऐसा कहते थे कि हमें जो कुंडली मिलाते हैं मेडिकल कुंडली जरूर मिलाना चाहिए, एंड ही यूज्ड टू ऑलवेज गिव दिस एग्जांपल. एंड बिकॉज ऑफ सर हमने इतने सीबीसी करवाए, just wanted to put in a little bit of my experience with this as well. इतने सीबीसी करवाए, I know that there are a couple of patients that I can remember जिनका 6th week में भी जब हम सीबीसी कराते थे for follow up, जब हीमोग्लोबिन कम आ रहा था even in the 6th week, then we sent them for thalassemia profile as well, and then a couple of them turned out to be carriers, and फिर उन्होंने अपने बच्चों का कराया, and it turned out that one of the child was also a carrier, which is something that they had not known. वो हमेशा यही कहते थे कि child weak है, and मतलब ये ऐसी ही है, शुरू से ही ऐसी ही है, and that was just a moment of a proud moment for us कि हमने ठीक है, of course there was not much to be done at that age, but जैसा आपने कहा कि 10 की उम्र के पहले अगर उसको पकड़ लिया, then there are a lot of things that they can probably do in the future. So that was just my two cents about it.
अगर आप देखा होगा ये मुझे जो पैशन है, चाहे ठीक है पहले पर डॉक्टर के अग्रवाल सर से मुझे इंस्पिरेशन बहुत मिलता है. मतलब मुझे अगर आपने देखा होगा कि मेरी जो टॉक है प्रैक्टिकल ज्यादा है, मेरा तो सो साइंटिफिक, मतलब जो करना क्या है वो बता रहे.
Absolutely.
इसलिए मैं मीनाक्षी आपसे कहना चाहूंगा, इफ यू वांट एक बार हेल्थ दरबार में अगर जनरल पब्लिक में आप चाहोगी तो विद इन इवन दिस वीक एनी डे इफ यू टेल मी, क्योंकि वहां तो बहुत अलग ब्रीफ 15-20 मिनट का हो सकता है.
वहां पे it is 15-20 minutes and it is more for laymen, so it is
layman, yes I'll do for layman. तो मेरा तो काम यही है. तो अगर आप किसी भी
if you like, I can even bring in a thalassemia major patient that we have. We can call her. She वो बहुत famously sir के videos पे आती हैं. I'm pretty sure she's listening in on Facebook.
आप नाम पता हो सकता मुझे जानती है.
ज्योति वाधवा है. This is the patient. So she used to call Sir Dadu, and she used to come here every day. Very young patient, and a very ardent follower of Sir. So yes. We'll do that. So once again, a big thank you to you, Dr. Arora, and a big thank you to you, Dr. Nidhi, for being here with us, for starting off our meeting with the overview that is much needed. And a big thank you to all of you for joining in, staying here, and keeping the show alive. We'll be back next week with another show. Until then, goodbye.
एक ही और करना. 14th June is the World Blood Donor Day. अगर उसके पास जो संडे as well of that.
Absolutely, sir.
ठीक है. Thank you.
Thank you, sir.